Hello everyone. The topic of my presentation is the ultrasound-guided ablation for hyperplastic parathyroid glands. I am Dr. Yu, work in the Department of Interventional Ultrasound in China, Japan, Friendship Hospital. The content include the case report, technical details, research results, and discussion and prospect. So, we first share the case report. The first case is female with 13 years old, and she held pregnant for 11 weeks. In the physical examination, shows the value of calcium is very higher than the normal range, and the value of phosphorus is decreased. The further examination revealed increased value of IPTH. The ultrasound showed the parathyroid glands could be proliferated in the inferior pool of left throat. So, the diagnosis is a primary hyperparathyroidism, Phpt. Then, how to manage a Phpt? The first is observation, but the high value of IPTH and calcium will harmful to the mother and baby. The second is medication, but perhaps some side effects influence the baby and mother. The resection in the radical method to remove the Phpt, but the trauma is very large. The first method is minimally invasive treatment. After we introduce the full method to the case and her relatives, they select the minimally invasive treatment, in other words, microablation. This the pro-ablation ultrasound shows there is a nodule behind the thyroid. It very close to the carotid artery and the trachea. The dynamic ultrasound shows the nodule is very close to the different critical structure, which includes the artery, the esophagus, trachea, and the recurrent laryngeal nerve. Because this is because the case have pregnant, so we have not perform the CUS. Before ablation, we use the PDC injected in the position between the nodule and the surrounding critical structure, and injection the normal swelling to separate the nodule far from the surrounding critical structure. So in this position, we think it is safe for to ablation. So the microwave antenna was punched into the nodule, guided by ultrasound. Then we start the power. The power is 13 watt, and the multiple point ablation was used. After the high echo covers the whole nodule, we stop the ablation. This is the process of ablation. You can see. In this position, is very far from the different critical structure, so we think this ablation is safe. After ablation, we use the ultrasound was used to monitor the baby. We can see the heartbeat of the baby is normal. Is removed. After ablation, the result of laboratory tests showed the value of IPTH decreased from 145 to 5.3, 5.2, and the value of calcium is decreased, and the value of phosphorus is increased. So as we think this is a complete ablation. This in the follow-up, the patient gave birth to healthy baby after a full-term pregnancy. The second case is female with 83 years old, and she had hyperparathyroidism crisis. The physical examination shows the value of IPTH is very high, is more than is 3.11, and the value of phosphorus is decreased. The further examination revealed increased value, which is more than 200 peak area per milliliter. The ultrasound showed hypoechnic nodule behind the left thyroid lobe. So, how to manage the Phpt? The observation, medication, resection on the minimally invasive treatment. Because if the observation is very dangerous for the case, the medication have no work for the high value of IPTH. Resection is dangerous for the old lady, and the minimally invasive perhaps can work for the patient. Before ablation, the ultrasound shows that there is very large nodule behind the left side of thyroid lobe. The maximum diameter of the nodule is 1.3 centimeter, and this dynamic ultrasound before ablation shows this nodule is very large and is very close to different critical structure. The CDFI shows there is blood signal within the nodule, and the MIB shows that there is radioactive concentration in the early and delay phase of the nodule. The before ablation, the CUS shows there is a hyper enhancement in the nodule, within the nodule. And before ablation, the PTC was punctured into the position between the nodule and the nerve to separate the nodule far from the nerve to prevent the heat injury during ablation. So we start the power to ablation. The multiple point ablation was used to have a complete ablation. After ablation, the CUS was used to evaluate the effect of microablation. We can see the nodule, there is no enhancement in the ablation zone, and the ablation zone covers the whole nodule. The results showed 1 day after ablation showed the value of IPTH is obviously decreased in the normal range, and the value of calcium is decreased, and there is no obviously change for the value of phosphorus. This is 1 month after ablation. 1 month after ablation, we can see the nodule is slightly shrink, and this is 3 months after ablation. In 3 months, the follow-up, the value of IPTH and calcium and phosphorus is in the normal range, and for monitor whether there is a local recurrence, we perform using the CUS. The CUS showed there is no enhancement within the nodule, which refer to the complete ablation. This is 3 months later. So the second is the technical details. How to find and identify hyperparathyroidism nodules. The first is use ultrasound, because ultrasound is very sensitive to disclose the low echo nodule. And CUS shown there is hyper enhancement in the artery phase, because this is hyper function in the nodule. So almost all the nodule is hyper enhancement in the artery phase. The third is the MIB. How to identify the boundary of hyperparathyroidism? So this is the Phpt nodule. Where is the boundary is difficult to identify. But during we injection the normal saline, we can see there is a clear boundary, and we can look at the The low echo nodule in the hyperplastic glands, and the surrounding high echo in the normal tissue of parathyroidism. So in this position, it's very clear. How to protect the surrounding critical structure during ablation. For example, this nodule, which is very close to the S-glass, trachea, and the recurrent laryngeal nerve. And before ablation, we use the PTC puncture into the nodule and between the nodule and the nerve to injection the normal saline to compress, remove the nodule far from the critical structure. So in this case, this nodule is far from the surrounding critical structure. So in this position, we think it is safe to for ablation the nodule because it's far from the surrounding structure. How to ensure the safety and efficiency of ablation? The answer is low power. Generally use 13 to 14 watt. Short time, we use 15 to 20 seconds in one point, and multiple point ablation was generally used. How to detect recurrent laryngeal nerve injury in time? The answer is real-time assessment of vocal cord motion by ultrasound. For example, this is a normal function of recurrent laryngeal nerve. We can see the vocal cord motion is symmetric, and in this case, this is a recurrent laryngeal nerve heat injury. We can see in the left side there is the abnormal movement. How to ensure complete ablation? For example, before ablation, the CUS shown that there is a hyper enhancement. Before ablation, we can see obviously hyper enhancement. After ablation, we can see this position. The nodule is no enhancement. So we think this is a complete ablation. How to find and deal with bleeding? Firstly, the ultrasound could the hematoma. The hematoma has special ultrasound feather. Is generally low echo and compress the thyroid. And if we find the bleeding, we can use the compression medicine on ablation to see the bleeding. The third part is research result. In our department, from 2014 to 2020, the total 285 cases of SHPT and 94 cases of Phpt have received have undergone the microablation. The power is 13 to 14 watt. All patients have complete ablation. This is we have published the different research result. This is a macro result of microwave ablation of Phpt. There are total 13 cases, and this is baseline. The 13 nodule in the normal location and 1 nodule in the ectopic location. The maximum diameter is about 1.8 centimeters. The before CUS, all of the nodule is hyper enhancement. After ablation, we can see the value of IPTH decreased from 234 before ablation to 17 2-hour ablation, 12 in one day ablation, 44 7-day ablation, and 15 6 1 month ablation, and 65 in the end of follow-up. The follow-up time is 9 months. the value of calcium is obviously decreased. You can see from 2.8 to 2.4. The phosphorus is increased, but there is no change of the value of ALP. This is the result of microablation of SHPT in a short time follow-up. There are total 118 cases, and this is 1 lesion, 2 lesions, 3, 4 lesions in these cases. After ablation, we can see the value of IPTH decreased from more than 1,000 to 324 hours later. The value of calcium and phosphorus is obviously decreased in 24 hours. This is a long-term follow-up of the result of microablation for SHPT. There are total 51 patients. After ablation, the value of IPTH, calcium, and phosphorus is obviously decreased. This is the result of microablation for SHPT after successful renal transplantation. There are total 9 cases enrolled in this study. This is baseline. And after ablation, we can see the value of IPTH, calcium, and phosphorus is obviously decreased. In the same time, the value of blood creatinine and antonin and blood urea nitrogen have no obviously change. In other words, the microablation have no influence to the transplantation renal. This is the microablation of SPT in ectopic position. The same result shows the value of IPTH, calcium, and phosphorus is obviously decreased. This is a microablation of SHPT for ineligible for surgery. The reason, this is baseline, the reason for ineligible surgery include recurrent SHPT, poor heart and lung function, renal transplantation, parathyroid glands located in a difficult to resect area, thoracic deformity, coronary stent implantation, advanced age, and underweight. The result shown after ablation, the value of IPTH and calcium and phosphorus is obviously decreased. You can see this result. The complication include major complication. The major complication include 1 case of recurrent laryngeal nerve injury. This case had aphonia in the follow-up time. The follow-up time is more than 3 years. The 1 case of local hematoma, 1 case of slight Horner syndrome, but this case is relative within 3 months after without treatment. 2 cases of skin necrosis caused by calcium supplementary. The adverse reaction include intraoperative pain, mild edema, hoarseness, and hypocalcemia. The first case is discussion and prospect. Microablation is a minimally invasive method for hyperparathyroidism because the microablation is performed under local anesthesia. The needle is very thin, and the ablation only affects the nodule and have no effect on other parts. The work cause ultrasound guidance and monitoring. So the microablation of PHPT and SPT is safe and effective. Prospective. The minimally invasive treatment is a trend for the treatment of parathyroidism. When the progression of research and technical details of ablation for hyperplastic parathyroid glands, it is possible that ablation will improve the traditional treatment pattern and benefit patients. Thank you for listening.